Welcome to Pediatric Tracheostomy Basics. This is Dr. Laura Sterney. This present will review the indications for tracheostomy, types of tracheostomy tubes, and basic tracheostomy care. A tracheostomy is a small surgical opening that is made in the neck and leads to the child's trachea. The opening is called the stoma. A tracheostomy tube is inserted into the stoma to aid with breathing. There are several common indications for tracheostomy placement in pediatric patients. The first is to bypass a blockage of the upper airway. For example, some children may have significant upper airway collapse that leads to severe obstructive sleep apnea. Children may also experience upper airway obstructions from congenital malformations of the airway or from subglottic stenosis, which can be seen in premature infants. The second common indication for tracheostomy is so that the tracheostomy can be used with a ventilator for patients with chronic respiratory failure. These include patients with neuromuscular disease, with chronic lung diseases like bronchopulmonary dysplasia, or with central hypoventilation. Lastly, sometimes tracheostomies are placed to assist patients who cannot cough and clear mucus from their lungs appropriately. In this case, the tracheostomy tube provides a port for suctioning. It is crucial to know why your patient has a tracheostomy, as this will help you plan your response to emergency situations. For example, you should know if your child can breathe on their own. Some children with central hypoventilation will not breathe spontaneously. You should know how long your patient can tolerate being off of the ventilator. Lastly, you should know whether your patient can move adequate air through their nose and mouth. This is important to know in case the tracheostomy tube is obstructed or falls out. Let's review the basic parts of a tracheostomy tube. The cannula is the portion of the tube that sits inside the trachea. The flange rests on the neck. Tracheostomy ties are attached to the flange. The adapter is used to connect the patient's ventilator circuit or something like a humidification moisture exchanger. The obturator is placed inside the tracheostomy tube when you are going to insert it and is removed after the tube is inserted. The obturator helps you guide the tracheostomy tube into the stoma. Some patients require a cuffed tracheostomy tube. The cuff is on the cannula, and when inflated, it creates a seal between the tracheostomy tube and the tracheal wall. This may help protect the patient from aspiration and also serves to optimize respiration in ventilated patients by eliminating leak. In pediatric patients, you may also see a flex-stand tracheostomy tube used. The extended length of the shaft prior to the adapter helps keep devices and ventilator connections away from the child's neck. The goal is to try to reduce risk of stoma irritation. As you can see, there are a number of different types of tracheostomy tubes. Further, tracheostomy tubes come in a variety of different lengths and diameters. The best tracheostomy tube for your patient will be determined by their otolaryngologist or ENT doctor. Remember, as children grow, the type of tracheostomy tube or the size of the tracheostomy tube they require may change. It is important that your patients follow up with their otolaryngologist at least yearly. All of a patient's caregivers should know the type of tracheostomy the patient is using. This should include the brand name and the size and type of the tracheostomy tube, for example, if it is cuffed or uncuffed. There are two devices that are commonly used by patients with tracheostomy tubes. The first is the humidification moisture exchanger, or HME. HMEs are extremely important for children when they're not connected to their ventilator. The HME helps keep the air they breathe in through the tracheostomy tube filtered, warm, and moistened. You will hear some people refer to an HME as an artificial nose. The goal of using an HME is to help reduce infections and to keep the secretions humidified and thin. Another common device placed on a tracheostomy tube is a speaking valve, or a Passy-Muir valve. The speaking valve helps direct air through the patient's vocal cords when they breathe out, allowing improvement in vocalization and speech. Caring for your patient's tracheostomy will help avoid the very common complications of a tracheostomy. Skin care at the tracheostomy site will help avoid skin breakdown and infections. Routine suctioning of the tracheostomy tube helps clear the airway and remove secretions, reducing the risk of obstruction and infection. Lastly, changing the tracheostomy tube at a frequency which will be determined by the patient's otolaryngologist, again helps reduce the risk of obstruction and infection. Cleaning the neck and the skin around the stoma should be done at least twice a day, but can be done more often if there are concerns. As with all tracheostomy care, it begins with being prepared and having your supplies close at hand. For cleaning of the skin around the tracheostomy stoma and the neck, we recommend having trach ties, sterile saline or water, hydrogen peroxide, cotton tip applicators, a washcloth, and if needed, a protective skin barrier such as Duoderm, close at hand when you begin. When cleaning the neck and the skin around the tracheostomy stoma, begin by gathering your supplies and washing your hands. You will then want to position the child, and if you are using a skin barrier at the site, remove the skin barrier. While holding the tracheostomy tube gently in place, you can clean around the stoma with sterile water using your cotton tip applicators. You can then dry the site with another cotton tip applicator. You can then clean the neck with a soft rag and mild soap and water or sterile water. You want to remember to wipe away from the stoma so that you're not pushing water into the stoma. You then dry the neck. Replace the tracheostomy ties. You'll want to replace tracheostomy ties 1 to 2 times a day or whenever they're wet or soiled to help prevent skin breakdown. If your patient is using a skin barrier, replace that if needed. As you clean the neck and stoma area, be sure to check for signs of redness, drainage, rash, dampness, or an unusual smell. These problems should be reported to your child's doctor. It is best to have 2 caregivers available when replacing the tracheostomy ties. One caregiver can hold the tracheostomy tube in place, while the second caregiver removes the old ties and helps get the new ties back on. Once you place the ties back on, after cleaning your patient's neck, you want to check that they are secure. One finger, and only one finger, should fit between the ties and the neck. Suctioning the tracheostomy tube is a routine part of tracheostomy care. Here again, you want to be prepared. Have all your supplies close by. For suctioning the tracheostomy tube, you will need your suction machine, sterile suction catheter, sterile gloves, sterile saline or water used to rinse the catheter, and a sterile cup. When suctioning the tracheostomy tube, gather your supplies and wash your hands. Pour your sterile water into the sterile cup. You may want to give your patient breaths with an ambu bag or extra oxygen prior to suctioning if prescribed by a physician. Then put on your sterile gloves. From this point on, don't touch anything with your suctioning hand. Connect the catheter to the suction machine with your dirty hand. Ask your child to cough if they can. This will help mobilize the secretions. You should then insert the sterile suction catheter to the depth specified by their doctor. Do this without suctioning. Plan ahead. You should know how deep the sterile catheter should be placed. Once you reach the length that is prescribed by the physician, you can apply suction. We recommend suctioning only for 5 seconds each pass and allowing 15 to 20 seconds between suctioning passes. If the secretions are thick, rinse the catheter by suctioning the sterile water that is in the cup between each pass or as needed. We recommend suctioning the patients until their secretions are clear, but a maximum of 5 passes for one session. You then want to consider resetting your supplies for the next session. Some suctioning key points to remember. Be sure to use a new catheter and sterile technique with each suctioning session. Only suction to the depth specified by the patient's doctor. Suctioning too deeply can cause irritation to the trachea and lead to granuloma formation. Assess your patient's secretions when you are suctioning. If you see signs of infection, such as a foul odor or discoloration, or bright red blood, contact the patient's doctor. Changing the tracheostomy tube is a very important part of tracheostomy care. For most patients, the tracheostomy tube is changed once a week, but it can be changed sooner if needed. Again, have all your supplies ready before starting. You want to be prepared. You'll need the patient's tracheostomy tube, one the same size as they are currently using, and one a size smaller. You'll need your suction machine and sterile catheters, a water-based lubricant, and all the supplies you had on hand when you were doing trach skincare. When changing the tracheostomy tube, it is really best to have 2 caregivers present and working together. Be sure you both wash your hands. Prepare the tube you will be inserting into the stoma. Attach the ties to the new tracheostomy tube. Be sure the obturator is in the tube and lubricate the tube. If your child has a cuff trach, you want to be sure the cuff on the new tube is working by inflating and deflating the cuff prior to placing the trach in the stoma. Position your patient and perform suctioning. You may want to give oxygen prior to changing the tracheostomy tube. Your patient should be positioned on their back with their neck supported by a blanket roll. Prepare to remove the old tracheostomy tube. If your child has a cuff tube, deflate the cuff. Loosen the trach ties while your partner holds the tracheostomy tube in place. You are then ready to remove the old tracheostomy tube and insert the new tracheostomy tube. It is recommended that you use your dominant hand to do this. Quickly remove the obturator once you have the new tracheostomy tube in place and secure the ties. You should then assess your child's breathing. If you are unable to insert the new tracheostomy tube, remain calm. Pull the tracheostomy tube out of the stoma, slightly reposition the child, and try again. If you are still unable to replace the tracheostomy tube, attempt to place the smaller size tracheostomy tube that you have had ready. If you are unable to get the smaller size tube in, assess your patient. Begin rescue breathing and CPR if needed. Call 911 and/or notify the patient's physician. When traveling with your patient with a tracheostomy, you want to be prepared for any emergency. We recommend traveling with a go bag, which contains the following: a portable suction machine, sterile suction catheters, normal saline, tracheostomy tubes, the patient's current size and one size smaller, extra tracheostomy ties, scissors, a water-based lubricant, and a bag valve mask, commonly called an ambu bag. It is also very smart to be sure someone in your party has a working phone. Thank you for listening to this presentation on tracheostomy basics.